Good morning or afternoon. Sorry if you had to log in again. We had some difficulties, but we thank you for your patience. Also, thank you for joining us on our very first AAPB webinar of 2018. Today's session is Professional Ethics and Standards, Part 1 on Biofeedback. We are very pleased that you can join us for the next 90 minutes as AAPB has partnered with BCIA to bring you a complimentary two-part series on ethics. My name is Jose Salas, and I will be your facilitator today. But before we get started, I just have a few housekeeping items to review with you. If you wish to receive continuing education credits for participating in this webinar, you are required to register. At the conclusion of today's presentation, you will receive an email from me with the session evaluation and a 5-question multiple choice exam. You must answer these questions to qualify for CE credit. Now, your phone will be muted automatically in consideration of our presenter and other attendees. Please use the question feature to send questions to me, the Cowen Company staff directly. I will compile them for the presenter at the conclusion of the webinar. Today's session will conclude at 2:30 p.m. Eastern Time. If we're unable to get to everyone's questions, please email me and I will send out follow-up communication to the speaker. Now, we also encourage you to join us next Friday for the second part of this webinar series and part 2 on neurofeedback. It is now my pleasure to introduce today's presenter, Donald Moss, PhD, is Dean, College of Integrative Medicine and Health Sciences at Saybrook University. There, he has built training programs in biofeedback, clinical hypnosis, integrative mental health, wellness coaching, and integrative functional nutrition. Moss has served as president of Division 30 of the American Psychological Association and president of the Association of Applied Psychophysiology and Biofeedback. He is also president of the Society for Clinical and Experimental Hypnosis and ethics chair for the Biofeedback Certification International Alliance. Moss is co-director of Foundations of Heart Rate Variability Biofeedback, co-author of Pathways to Illness, Pathways to Health, and chief editor of Handbook of Mind-Body Medicine for Primary and Humanistic and Transpersonal Psychology. He has a book in preparation for Springer with co-author Angel McGrady and on integrative pathways, navigating chronic illness with a mind-body-spirit approach, and one for AAPB with co-editor Ina Kazan on mindfulness, compassion, and biofeedback practice. I will now turn it over to our very distinguished presenter, Dr. Donald Moss. Thank you.
Thank you, Jose, for that generous introduction. I want to call our attendees' attention to my email, which is on your first slide. It's dmoss@saybrook.edu. That's my university, Saybrook University. Our topic is professional ethics and standards, and today is part 1, biofeedback. Our topics today, our learning objectives are that each of you who attends this webinar will come to understand basic concepts of medical ethics. That's what I will begin with. Then I will turn and look at the ethical principles and code of conduct of the American Psychological Association. Many of you are probably not psychologists, but the APA has a particularly well-developed set of ethical principles, and I think it's worthwhile spending time looking at those because they're also a kind of a paradigm to understand the ethics within biofeedback. We also will cover the professional standards and ethical principles of biofeedback, which is a document published by BCIA, and a very similar version is published and endorsed by AAPB. We will be looking at these professional standards and ethical principles for biofeedback and how they apply to some of the everyday decisions we all need to make in clinical biofeedback practice. I will also talk somewhat about the conflicting jurisdictions. Each of us not only has our home profession, whether you're a physician or a nurse or a physical therapist, counselor, or psychologist, we have our home codes of conduct from our professional association. We have our state laws and regulation. We have the BCIA guidelines, and we also have federal regulations, and we need to be aware of and follow each of these. We're also going to talk about entry-level competence. Those of you who seek BCIA certification are assuring that you master all of the knowledge and all of the skills, assuring that you have entry-level competence for biofeedback practice. And then, of course, each of us is responsible as well for continuing education, which then assures that we remain up to date with current best practices in biofeedback. Finally, we have scope of practice depending on our home profession. As a psychologist, I may learn a lot about functional nutrition, but in my state, my scope of practice as a psychologist doesn't allow me to give even simple nutritional advice to my patients. I can help my patients to manage lifestyle changes, to follow good dietary practices, but I can't recommend specific dietary supplements or dietary changes. I also will touch on principles and guidelines for biofeedback practitioners on touching patients and attaching electrodes, which is important because although a nurse or a physician may regularly touch their patient in the course of their standard practice, for the most part, mental health professionals have restrictions on how much touch should happen between doctor and patient. So I'm going to turn first of all to some ancient history, basic concepts of medical ethics, and we can already go back to the Hippocratic Oath developed by Hippocrates, early pioneer in Western medicine. I'm going to begin with a modern rewording which takes the Greek Hippocratic Oath and translates it into present day terms. In the oath, we have the following clauses. I swear to fulfill to the best of my ability and judgment this covenant. I will respect the hard-won scientific gains of those physicians in whose steps I walk, and gladly share such knowledge as is mine with those who are to follow. Well, this means for our practice, for the field of biofeedback, that we all stand on the shoulders of others who have gone before us. Our field is relatively new. The first major scientific meeting in biofeedback happened in 1969, and many of the pioneers who were present at that time continue to attend annual meetings of AAPB and ISNR. And we have to recognize the efforts and achievements of these pioneers who have given us the field that we now practice. In turn, we have an obligation to share our knowledge with the students and the early career professionals who are coming into the field. We have an obligation to our patients, and the next clause in the Hippocratic Oath says, I will apply for the benefit of the sick all measures that are required, avoiding those twin traps of overtreatment and therapeutic nihilism. In other words, I won't provide unnecessary treatment simply to enlarge my bill, and I won't give up and throw in the towel when there may be additional therapeutic interventions which either I can provide or for which I can refer this patient. I've had the experience once in my adult life that my wife had a very severe condition, blinding her almost completely, and the first retinal specialist we visited told us that she simply had to accept and said, I know you're a psychologist, I suggest you help her accept her blindness. Well, this was a brand new condition. She hadn't even undergone any testing. We went on to a much more competent and ethical professional at the Kresge Eye Institute, who did a series of retinal laser surgeries, and she recovered not all of her sight, but a good part of her sight. So that would be therapeutic nihilism, giving up when there's still a great deal to gain from further intervention. I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. Well, this applies very well to biofeedback. Early research by Ed Taub showed that the warmth of the biofeedback practitioner, or in his case, a research technician, the warmth of the technician made all of the difference in a hand warming study, where all of the research participants who were assigned to one technician quickly learned to warm their hands, and she was a warm, empathic, touchy person. The second technician was trying very hard to be cool, impersonal, and technical, scientific in a sense, and her patient or her participants in the study could not manage, many of them, to even learn how to warm their hands. So it is true that we are in a technical field where we have a lot of technique to learn, a lot of psychophysiology, a lot of technology, but it's also true that we are sitting with another human being in the office, and our warmth, our empathy, and the communication of our liking and understanding for this person are very important in the success of our interventions. I also will not be ashamed to say, I know not, nor will I fail to call in my colleagues when the skills of another are needed for a patient's recovery. If I have reached the end of my toolbox for anxiety disorder and the patient is still not improving, it may be quite possible that a hypnotherapist or a cognitive behavioral therapist or someone else in practice in my region may be more successful with this particular person for whatever reason. And at that point, my ethical responsibility is to seek additional treatment. Here comes another very timely clause in the original Hippocratic Oath. I will respect the privacy of my patients, for their problems are not disclosed to me that the world may know. Most especially must I tread with care in matters of life and death. If it is given to me to save a life, all thanks. But it may also be within my power to take a life. This awesome responsibility must be faced with humbleness and awareness. So, number one, respect the privacy of our patients. The concept of confidentiality is very important. And in today's world, there are many limits on confidentiality. Some people think of HIPAA as protecting the patient, but HIPAA also allows disclosure of routine medical information among various treatment providers. So we have a responsibility not to write into those parts of the treatment record which may be shared private information which isn't necessarily required for successful, competent treatment in the future. And many lawsuits have resulted because people have written very private information into a progress note, which then was shared with workers' comp and became distributed to a wider number of people. So the second part of this, again, we may not with biofeedback engage in life-threatening surgeries, but it's certainly true that occasionally biofeedback training misfires and does cause health problems. And we have to be very attentive for the possibility that we may be doing the wrong treatment for this person at this time. The next clause from the Hippocratic Oath reminds us of holism and is kind of a person-centered orientation. I do not treat a fever chart. I do not treat a cancerous growth. Rather, I treat a sick human being whose illness may affect the person's family and economic stability. So what are the personal consequences, the familial consequences, and the financial consequences of the treatments that I choose for this person or recommend for this person? I have to recognize the whole human being and not just their symptoms. The next clause has to do with a preventive or a wellness orientation. I will prevent disease whenever I can, for prevention is preferable to cure. I remember specific health maintenance organization provider contracts that I had to decide whether to sign and whether to work with these particular programs. And one of the ones that bothered me the most stated that the treatment was designed to return the person to their status prior to the onset of symptoms. And my orientation has always been to introduce as many principles of wellness, principles of positive lifestyle, positive behaviors, wellness-oriented behaviors, acquired regulation skills, so the person would be healthier than before the onset of symptoms and would be more likely in the future to fight off the onset of symptoms because of the positive elements my treatment has introduced for them. So I never accepted that concept that we simply should return people to the best condition they had prior to these symptoms. The next clauses in the Hippocratic Oath say that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body as well as the infirm. And I know many practitioners in the field of biofeedback exemplify this very well, donating time to community organizations, churches, sports teams, providing wellness interventions, providing training in relaxation, autogenic training, mindfulness skills, just a variety of things that are beneficial to spread through the community. I've never feared that I would lose business because I would unleash too much wellness. If anything, the more interventions I've provided on a voluntary basis in the community, the more solid my own practice always was, because people would realize the point where they needed professional intervention. If I do not violate this oath, may I enjoy life and art, respected while I live and remembered with affection thereafter. May I always act so as to preserve the finest traditions of my calling, and may I long experience the joy of healing those who seek my health. And this is a part of every healthcare provider's life. When we do a good job and dedicate ourselves to our patients, it's often that we receive some kind of recognition even years later. I recently received a Facebook Messenger message from someone who wanted my email so they could, actually wanted my street address so they could send me a Christmas card with a letter of gratitude for a treatment that I cannot even remember in past years. And it was really quite touching. And this is part of what we accomplish in our professional work. Finally, this is a direct translation, not reworded for modern times, but a direct translation from the original Hippocratic Oath, and it still remains timely. Whatever houses I may visit, I will come for the benefit of the sick, free of all intentional injustice, of all mischief, and in particular of sexual relations with both female and male persons, be they free or slaves. Well, with the recognition of the danger of dual relationships, we are cautioned just as much today as in the time of the ancient Greeks that sexual relationships with patients or family members of patients are not acceptable. They're not ethical behavior because we're abusing a relationship of power and influence. I'm going to shift now and look at some of the very cornerstone principles in modern medical ethics. And the first principle of medical ethics is beneficence, which means that as a professional, I conduct the treatment process for my patient's well-being, for the patient's good. Edmund Pellegrino, who's a long-recognized expert in the field of medical ethics, translate this as meaning that healing is the fundamental principle of medical ethics. We might think, for example, that repetitive and sometimes even risky cosmetic surgery is controversial because we're feeding perhaps somebody's low self-esteem and dissatisfaction with a very normal body when we continually refer them for further cosmetic surgery, which may even have some risk. In one case, I know a woman who underwent cosmetic surgery, and there was an anesthesia accident, which left her in not a vegetative state, but the state of a child, that she is not now at an adult mental level. And this was for a rather superficial cosmetic change that she thought was somehow essential to her positive self-esteem. Euthanasia is not necessarily bad, but it's certainly something we have to think about and recognize. For example, if someone is suffering with treatable depression, and not all positive options have been yet explored, assisting in a so-called mercy killing is certainly very controversial. The second foundational principle of medical ethics is non-maleficence, meaning that we carry out our treatment in such a way as to avoid harm. Recent examples might be the psychologist who designed and implemented torture at Guantanamo. We can't really see that as non-maleficent because there was great harm and great suffering from their interventions. For the biofeedback practitioner, this primarily means that we have to become aware of and minimize the impact of adverse treatment. I'll give you a clinical example later. If you're here next week, I will be focusing on neurofeedback, and I'm aware of a case study where a good, well-designed neurofeedback intervention nevertheless set off a hypertensive crisis because even though the protocol was followed, it was a protocol which was not appropriate for the specific neural baseline this patient was exhibiting. So it also could mean, non-maleficence could mean we seek to avoid harm by giving a less than optimal choice of treatment. If we find that a patient is not responding to the treatment we're providing, persisting in that treatment may violate the principle of non-maleficence, because we could easily shift our own treatment strategy or make a referral to someone who may have a treatment intervention that's more appropriate for this particular person. Fidelity and responsibility signifies that we build a relationship of trust with our patient, we remain faithful to professional standards, and we accept responsibility for our own actions. Now, for example, I had a colleague who I think was very skillful and helped a great number of his patients, but I think he violated that relationship of trust because he would almost always prescribe a very extensive array of psychological tests, many of which were not necessarily helpful in designing the treatment for specific presenting problems or for specific patients. He also conveyed to them that their insurance would cover the psychological testing, even though he knew that specific insurances would not cover. And he always feigned surprise and developed treatment contracts and even became a hero for some of those patients because he reduced the total amount of the bill, showing that he was considerate of them, and yet he ran up the bill in the first place knowing that their insurance would not cover, which is a violation of trust. Autonomy signifies that we will conduct the treatment fashion in a process to respect and preserve the autonomy of the patient. Now, this follows the humanistic principle that each human being has a right to self-determination. Today, the primary way that we implement autonomy is to follow what we would call truly informed consent. In other words, we're going to present the patient with an array of options. What are the possible treatments we can provide or others could provide for their presenting complaint? We no longer follow the doctor knows best principle, which was very common when I entered practice. It was assumed that the physician or the biofeedback provider or psychologist would really know the field better, and the patient could not possibly understand the technical information available, and therefore we would make decisions about what treatment would be provided. And the patient often had very little understanding that what we were providing them was one of a series of options. Well, first of all, we have to recognize the reality that our patients have often been online and have a great deal of information about available treatments. It's not unusual for me to take in a patient who asks for heart rate variability biofeedback or some other specialized intervention because they've been online and they not only know that this is an option for, let's say, an anxiety disorder, but they know that I've published in that area. So we have to, in this new reality, it's no longer even practical to pretend that the doctor knows best. We have to make decisions for the patient we can't make decisions for the patient, rather. We have to fully disclose what are the options, what are the implications of each treatment decision, and then invite the patient to discuss and make the final decision. For example, even though I may recommend neurofeedback, I have to explain that the neurofeedback intervention for, let's say, attention deficit disorder is typically 40 to 60 sessions. There are patients who respond in 20 to 30, but it's more commonly 40 to 60, at least in most practitioners' experience. Or, for example, turning to a patient who comes into our office for a headache, but we discover in the course of the evaluation that they're having an emergence of early traumatic memories from early sexual abuse. And the patient talks to us about undertaking psychotherapy to address the early traumatic experiences. And we recognize some dissociative elements in their presentation. We have a responsibility to let them know that, yes, we'll be happy to either provide that treatment ourselves if it's part of our training, or refer them to a colleague who could do the psychotherapy while we work with them on their headache. But we have a responsibility to let them know that that type of treatment is likely to be at least many, many months, and in some cases, many years. I remember one patient where I didn't even recognize early in treatment that this was the actual problem. She was referred for headaches and postpartum depression. But it turned out to be a series of early childhood sexual abuse incidents. And her treatment was probably 4 years. And she said she really was not sure if she would have undertaken the exploration of the early abuse if she realized not only how lengthy, how costly, but also how painful the process of self-exploration was. She finally concluded she would have done it because she felt that she had become a much healthier person. But those are the kinds of things, if we have that recognition, autonomy says we should share it with the patient. Now, justice says that we will cultivate a sense of fairness and justice, and we will allow those principles to govern our treatment relationships. One example for a biofeedback practitioner may mean that every prospective patient is entitled to access to treatment and to equal quality in service and therapeutics. In my state, for many presenting complaints, Blue Cross Blue Shield specifically excluded biofeedback. And I had to let the patients know I could design for them a psychotherapeutic treatment, which will include some relaxation training supplemented by referral to a relaxation skills class that fortunately has been available in my community. But I also let them know that there was another treatment with biofeedback for which there was better evidence for their particular complaint, and that I would like to do that treatment, but they would have to self-pay, or they could file an appeal through their physician with their insurance. So we let them know what we can do under the terms of their insurance, but we also let them know that if somebody else with a different insurance came in, that is not what we necessarily would recommend. So that's an example where justice would say the person should understand the full situation. Justice also might lead us to question the terms of a provider contract that told us that we couldn't provide adequate quality of care for specific subgroups of patients. This is no longer true for any of the companies I work with, but in the past I had provider contracts which limited adolescent treatment to 8 sessions in most cases, and I know that most adolescent treatment takes much longer. So I specialize in brief forms of treatment, but I also know that adolescence is a time of identity transitions and emotional turmoil, and realistically, I've rarely treated an adolescent in 8 sessions. Okay, I'm going to shift PowerPoints at this moment. But as Jose said, if you have any questions for me, please put them into the chat box, and he will read them at the end, and we will discuss them. I'll stop early enough that we should have some time for discussion. Okay, now I'm turning to the 2010 version of the American Psychological Association Ethical Principles for Psychologists and Code of Conduct. Now, first of all, and I think this applies very well in most situations in biofeedback as well, if we become aware that an ethical violation has occurred, we attempt to resolve the issue by bringing the violation to the attention of our colleague who we think is violating the code. Now, we might not do this for a very severe violation, but for example, if we have seen somebody's business card and the wording on that card lists their AAPB membership or their ISNR membership as their evidence of their competence. We know that certification can be advertised. Our healthcare license or our social work certification or our nutritional license can be advertised, but membership in a professional association does not constitute evidence of competence. So this is an ethical violation, but it's a minor violation that we would usually begin by talking to our colleague and saying, you really need to redo your business cards because they're in violation of the Biofeedback Code of Conduct, the PSEP, Professional Standards and Ethical Principles for Biofeedback. Another example similar would be somebody who has a PhD in nuclear physics and has completed a biofeedback training program for which they have a certificate but not BCIA certification, and the person advertised themselves as a biofeedback practitioner with a PhD, and yet the PhD is not in a healthcare field or a field relevant to their practice, which is also a violation of the BCIA standards. So those are the kind of small things we would first bring to our colleague before we would do anything else. When the violation is more serious, we take action appropriate to the situation, such as referral to a state or national ethics committee, licensing board, or institutional authority. The APA guidelines say that we need to be competent in order to work with any population of clinical patients. So we provide services, we teach, and we conduct research only with populations and in areas which are within the boundaries of our competence based on our education, our training, our supervised experience, our consultation, our study, or our professional experience. I may know how to use an EEG, but if I've never in my life treated an individual with dissociative identity disorder or bipolar disorder, and I haven't been trained or supervised in treating such people, then using the EEG is very risky with those patient groups unless I work under supervision with a professional supervisor or mentor who has the knowledge to help me deal appropriately with these clinical populations that are outside my experience. Human relationships, there are very fundamental simple principles in the APA code. Psychologists don't engage in unfair discrimination. We don't engage in sexual harassment. That's very timely today. We don't engage in other kinds of harassment. And we take steps to avoid harm to our patients. Now, those seem like very simple clauses or principles, but I'll give you an example which makes it a little harder. We shouldn't discriminate. Well, what does that mean? It certainly means I'm not going to turn someone down because of their gender or their skin color or their ethnic background. But what if I belong myself to a religion which is extremely conservative and tells me that homosexuality is a sin, and I can't get past my own religious belief that it's a sin to be accepting and empathic toward a person who's gay? If that's the case, even though this principle would say we shouldn't discriminate, on the other hand, we probably can't provide fair supportive and empathic treatment. So we may have to say, because of my personal limitations, I think you would be better off with another therapist. We're not denying them treatment, but we're helping them get to a therapist who is more empathic and accepting of them and better able to provide what they need. We should refrain from entering into multiple relationships if the multiple relationship could reasonably be expected to impair our objectivity, our competence, or our effectiveness in performing our functions as a psychologist, or otherwise would risk exploiting or harming the person with whom we have the professional relationship. Now, when I came into the field, it was quite common to barter with patients. If they didn't have the money for treatment, we might ask them to perform certain services. The APA doesn't absolutely exclude barter, but it cautions in its ethical guidelines that barter can be a dual relationship, which is harmful. And I actually experienced that. Again, early, I wouldn't do it today, but early in my career, I contracted with a person that because they couldn't pay even a reduced fee, they would do some work with me getting rid of an old furnace in my basement and some other similar kinds of contractual work in exchange for their reduced fee. Well, as it happened, the person was very unreliable, didn't come when scheduled, didn't answer my telephone calls, and never completed the work. So now I was in a situation where I was frustrated and impatient and angry with the person, and yet I was still attempting to provide empathic and supportive relationship in the therapeutic realm. So this is a good example why dual relationships or multiple relationships can be destructive. Multiple relationships that could not reasonably be expected to cause impairment are not unethical, but we really have to be very careful around them. Sexual involvement with patients, the relatives of patients, former patients, students, supervisees, etc., are prohibited under ethical codes. The licensing and regulation and the APA only prosecute providers who are involved with somebody during treatment or in the first 2 years after treatment. But the fundamental principle is that once a patient, always a patient. And I certainly have learned that it's fortunate that we stay more detached from dual relationships with former patients, because I've had former patients who got a great deal of benefit returning to therapy 10 years, 15 years, and even 20 years after their original treatment contact. If I had casually become involved with one of them, let's say 5 years after treatment, it might not have been a crime, it might not have been a prosecutable ethical violation, but it would have denied that person the ability to turn to me again as somebody who already had established an effective treatment relationship and often could provide very effective treatment in a short time because of that earlier therapeutic effectiveness. We don't exploit people over whom we have supervisory, evaluative, or other authority, such as our patients, our students, our supervisees, our research participants, or our employees. When indicated and professionally appropriate, psychologists cooperate with other professionals in order to serve their patients or clients effectively and appropriately. These are all good principles for biofeedback practitioners to be aware of. I will give you an example today, if time allows, to illustrate this idea that even, for example, somebody we provide biofeedback mentoring, that is one professional relationship, and in a case that I will discuss, a biofeedback provider took on his former mentee. He had done BCIA mentoring for this professional, later took her on as a personal therapeutic patient, and it led to a dual relationship situation which led to a complaint. because he couldn't navigate both of those relationships entirely without undermining one or the other. Moving on, I've mentioned informed consent before. When we do research, when we provide assessment, when we do therapy, counseling, or serve as a consultant, we obtain the informed consent of the individual or individuals using language that is reasonably understandable, except when conducting such activities when conducting such activities is mandated by law or governmental regulation and consent is not needed. So, for example, I may be ordered to evaluate a prisoner, and the prisoner may not have the right to refuse the evaluation. For example, I might evaluate competence to face trial, but my informed consent with the patient then has to be that I am hired by the court. What you tell me is not confidential and will be utilized for me to provide an evaluation and a report to the court based on information you disclose to me. So I'm acknowledging to the patient that person shouldn't trust some kind of confidentiality when that confidentiality in this situation does not exist. So we have an important responsibility to disclose the limits of confidentiality with each person we work with. Interrupting services. This is something that each of us in our career may face on more than one occasion. I went through a major shutdown of a psychiatric clinic in Pittsburgh where I was doing my internship. And that was a 1-year-long process of planning and careful discharging of patients. It was a real learning experience. We did a careful informing of the patients and a methodical referring out to appropriate services, careful evaluation as to who would provide the best services for each patient. But sometimes the psychologist or the biofeedback practitioner dies, becomes ill, faces retirement or relocation, all of which we can't entirely avoid in our lifetimes. So then it becomes important to facilitate a transfer, to give as much notice as possible. I've jokingly told my patients I would try to give them at least 90 days notice if I intended to die, but of course we don't really have those timelines. So if we have the timeline, we can provide as much continuity as possible, and we have the responsibility to do it. Lawsuits have been filed for abandonment when people abruptly terminate without providing adequate transition, and the best planning we can do minimizes that risk of a lawsuit. Under privacy and confidentiality, we have to protect our confidential information. Most of us are more aware of that today. Laptops are stolen and lost daily. If confidential information is kept on laptops, it should be protected, encrypted. We should actually offload information that's not necessary to be kept any longer on those laptops. So we need to find what are the guidelines for confidentiality that we need to follow to protect ourselves. I store my patient records from 2 clinics that I closed in a storage room with 2 doors that someone would have to break through, 2 deadbolted doors to get to those records, but we don't all have access to that same level of security. Discussing the limits of confidentiality. Well, if I am providing care to someone who is involved in a workers' compensation claim or an auto accident claim, I should warn them that they may have rights of confidentiality, but if they would refuse to disclose my record, it would undermine their ability to gain a claim for workers' comp or auto accident compensation, because the court would perceive them as blocking necessary discovery for the opposing party who doesn't want to pay the money. Now, I try to be aware of this as a knowledgeable professional and keep rather minimized progress notes, providing important information but less personal information in the progress note than I used to provide, because I'm quite aware that my progress notes will be reviewed by strangers and in some cases will be released to people who aren't necessarily sympathetic to the patient. They also, in all probability, will be released to the patient. So we all have to write our notes with that knowledge and choose our language and what we disclose appropriately. We face similar limitations on confidentiality when we're involved with divorcing parties who have children, because family courts will frequently ignore confidentiality and force disclosure of treatment. We can minimize intrusions on privacy by including only information which is germane and necessary for the purpose of the communication. And we can discuss in our teaching or in our scientific writing, we can be careful to limit the personal details that are disclosed in our case narratives, for example. I'm going to move along here. I don't want to short circuit this area too much, because this is actually one of the areas which is most often going to lead to litigation for any healthcare or mental health care professional. We should be aware that we only disclose confidential information without that person's consent as required by law or when permitted by law for a valid purpose. For example, if I need to disclose the patient's information because the person, I regard that patient as threatening violence to others, then I'm going to be obliged to disclose that to police or to the family. If I discover that a person who is in a vulnerable situation, meaning a developmentally disabled person, a mentally ill person, is being abused, exploited by someone, sexually or otherwise, I have the right, I have the responsibility to make that disclosure to protect them from future abuse. I may disclose limited amounts of information in order to obtain payment, even to go to collections, but that's very limited amounts of information, such as the date of service and the nature of service. Once again, returning to our writings, our lectures, our public disclosures, the best principle is to obtain informed consent, specifically allowing the use of that patient's information in research or teaching. Secondly, to disguise the information and remove personal details, or again, to obtain some kind of legal authorization. And I should caution here that having a subpoena is not necessarily adequate cause. One of my supervisees was sued because he responded to a subpoena and disclosed some very controversial personal information in a divorce case. I had a contract with that supervisee saying he would never disclose information without previous discussion with me, and he violated our supervision contract by disclosing this information without discussion, and I knew immediately that he was going to probably end up with a lawsuit because he disclosed confidential information about one spouse to the other spouse's attorney. He should have attempted to what's called quash the subpoena or block the subpoena in court to protect his patient's right to confidentiality. There was not an adequate legal cause to violate the confidentiality. And his insurance did have to pay a penalty for that action. Okay, now we're shifting directly to the field of biofeedback. And I'm going to utilize the professional standards and ethical principles of the BCIA, the Biofeedback Certification International Alliance, and I'm using the version that's online, which is the 9th edition. This document has been revised repeatedly over the course of years to handle contemporary issues as they arise. Now, why do we have ethical standards? Well, ethical standards are intended to protect the general public from harm. That's what we usually think of. We also, though, are protecting the field of biofeedback from harm, because if we have clear guidelines and our providers follow them, it avoids controversial situations which would undermine the reputation of biofeedback. We also protect the professions that deliver biofeedback services and the providers, because if someone files a complaint against me that I've done something inappropriate, and I can show that it is the best practice in my field, I can call on several colleagues or a research paper published showing the clinical efficacy or clinical effectiveness of what I've done, and I can show that I acted in accordance with the BCIA PSEP, Professional Standards Document, I'm less likely to have a judgment made against me. So I encourage all of you to go online and read the Professional Standards and Ethical Principles of Biofeedback document. But you also need to read your own licensing act, whatever your home profession. If you're a physical therapist, a nurse, a nutritionist, a neurofeedback practitioner who has a counseling degree and license, whatever your home profession is, you have to be aware of your own licensing act in your state, as well as your professional code of ethics. For example, I am a psychologist, so I have to stay in touch with changes in the APA code. Physician practitioners need to follow medical ethics, psychologists the ethical standards of the APA, and so on. Now, on the other hand, we have to be aware of what is the subgroup or the community, the subculture that we're serving, because there are community norms about what's healthy and appropriate behavior, and they may sometimes create a situation which puts us at odds with our professional guidelines. The APA guideline, which I've just gone through, recommends against maintaining a dual relationship with a client, such as friendship. But that may be a problem if you live in, let's say, the Four Corners area and you're working with a Navajo community where it's expected that a healer should visit the family and participate in community religious rituals along with the sufferer. So suddenly you have to balance, how shall I behave? I will go to this ritual, community ritual. I will invite the entire family to my office, or I will visit the entire family to create a sense of trust for my individual patient. And the patient may include family members more frequently than someone who's in an urban setting. So that's an example of balancing our guidelines against cultural norms in each subgroup that we interact with. Well, what are our responsibilities? First of all, we are responsible. It's important that we gain entry-level competence in biofeedback, and then that we continue to expand our expertise through activities like continuing education. If you gain BCIA certification, which I highly recommend, this ensures that you have entry-level training, skills, and knowledge. It doesn't mean you have the highest levels of expertise, but it means you understand the equipment, you understand sensor placement, you understand treatment protocols for a variety of common disorders. And then we have the responsibility to read the biofeedback magazine, to read neuroregulation if you're a neurofeedback practitioner, to read applied psychophysiology and biofeedback if you're practicing biofeedback, and to go to state, regional, and national meetings, at least periodically. This is the way that we keep up with breakthroughs and progress in the field. We protect our clients' welfare by appreciating what is the impact on their life of what I'm doing and of the cost of what I'm doing. We have to recognize potentials for conflict of interest and make an open discussion with our patient about any such conflicts. If I'm not sure what the best treatment is for a specific patient with their presenting problem, it's time that I either utilize clinical supervision or peer mentoring. For many years, I worked very closely with a licensed psychologist, and every time either one of us had a question in our mind, even the slightest question, we would check each other's schedules and walk down the hall and sit down and share the details of the case and the question that had arisen, therefore providing objective, qualified supervision by someone else who has similar credentials and is capable of giving us professional perspective on the question we're raising. If I'm going into my client presents something that's brand new to me, I may have to go outside my current peers and contact somebody who specializes in that area and obtain some peer supervision, even at a distance. With Skype or GoToMeeting, I can obtain guidance. For example, if I recognize that a patient that I'm dealing with really needs pelvic floor biofeedback, I've actually gone through some workshops, but I haven't made it part of my practice. In my community, I don't have to, because there are some good nurses and physical therapists who are doing pelvic floor biofeedback. But if I lived in a community where somebody really needed this treatment, I had the EMG skills, and I'd done some training, some workshops on pelvic floor, but I'd never treated pelvic floor. I would then obtain clinical supervision at a distance with somebody who is expert and well-trained in this area before I would proceed to provide such care. Competent providers, we are critical consumers of research. We stay informed of relevant findings. We recognize when biofeedback is indicated, when it isn't, and we can critically evaluate the efficacy of biofeedback applications. I strongly recommend, if you don't already have a copy, buy the book, which is published by AAPB, called Evidence-Based Practice in Biofeedback and Neurofeedback. Because that book, it doesn't provide all the detail on exactly how to carry out each treatment, but it provides very reliable summaries of the research on each application area, such as fibromyalgia, diabetes, chronic pain, how well biofeedback is supported as efficacious by the research literature. And this is what we're responsible to know. Now, we might have a particular new treatment that we're excited about. We're fascinated with it. We can't wait to try it out. And I may have a patient who I would love to try it out with, but there is a well-documented effective treatment that's much better proven for this patient's problems. I have the responsibility to say to the patient, I've got a new treatment that I'd really love for you to try, but I have to tell you that right now the state of the art, the best research supports, let's say, cognitive behavioral therapy or neurofeedback. I want to try heart rate variability, but the best research is actually on hypnosis or neurofeedback. If the person consents and says, sure, I'll try this one you want to try with me, that's fine. Then we've informed them and they've made a well-informed decision. But we don't have the right to secretly make the decision that we're going to use our pet therapy with them. So if you're going to use something that's not yet very well documented, informed consent is necessary, and I recommend that you get informed consent that's written. When I first began to use audiovisual stimulation, it was new to me. It was relatively unknown in the field, and I was dealing with many patients who had migraines and headache, seizure disorder. So I made a practice of consulting with their primary care physician. If they were seeing a neurologist, I consulted the neurologist, and I I developed an informed consent describing any possible side effects and the possible benefits and the limits of the research. And in most cases, the patients consented. The physicians were sometimes nervous and wanted regular contact, but patients got a lot of value from those early uses of audiovisual stimulation for those patients. And I was glad that I had persuaded them to try this therapeutic intervention. But I did it with well-informed consent, and I had a written record of my correspondence with the physicians as well as the patient's informed consent. Now, we also have to be aware of the scope of practice defined by state law and regulations for our own profession. As I mentioned earlier, as a psychologist in Michigan, I can't recommend any nutritional intervention. It's simply prohibited in my scope of practice. There have been some efforts made recently to open up simple nutritional recommendations to mental health providers, but that hasn't been achieved in my state. In some states, psychologists may not engage in massage therapy with the patient who's present for a psychotherapy session, even if the psychologist is also a massage therapist. One of my graduates from Saybrook is a certified massage therapist and a licensed professional counselor. In North Carolina, the licensing board gave her endorsement to say that, yes, it's appropriate in your practice if you wish to use both counseling and massage in the same session, for example, with a patient who had a chronic pain problem or post-traumatic stress disorder. It is often helpful to combine modalities, but she could do that in one session. In our clinic, I had to utilize an on-site massage therapist, and the sessions had to be scheduled next to each other, not in the same time period. So I could come into the massage session and talk with the massage therapist and the patient with the patient's permission. The massage therapist could visit my session doing heart rate variability and psychotherapy with the patient, but they could not be the same session because of our state laws. So those are the kinds of things we have to recognize. Scope of practice is defined locally by our own state. Or there was one other example here. A health coach may seek certification in biofeedback. Many health coaches use heart rate variability, especially the M-Wave, but they may not diagnose a medical or psychiatric condition. Under the current ethical guidelines, if they wish to treat a diagnosed disorder, they must work under supervision of a licensed healthcare provider. They may provide relaxation training, basic heart rate variability training to optimize wellness and resilience, but they can't provide so-called treatment for an anxiety disorder or a clinical depression. So our scope of practice is defined by state laws and regulations. Oops, there we are. Our scope of practice is also limited by our knowledge and experience. Even though my license may allow certain areas of practice, if I haven't yet gained competence in those areas, it's unethical for me to provide such treatment. Now I'm going to provide you, in the time remaining, I'm going to try to stop about 22 minutes after the hour, but I'm going to go through a couple of clinical challenges from cases that have come to my attention, been brought to my attention over the years. So here's one which I kind of touched on a couple of minutes ago, and it has to do with scope of practice. This individual, Sander, was a licensed psychologist. He was BCAA certified in general biofeedback, and he was also licensed as a nutrition counselor. He developed an integrative model for treating anxiety, stress-related medical disorders, attention deficit and hyperactivity disorders as well. And he used a combination of psychological testing, nutritional testing, including hair mineral analysis, and clinical interviews to develop a holistic evaluation of each patient. He found that many of his patients improved more rapidly when he combined nutritional supplements, psychotherapy, biofeedback, and actually neurofeedback as well. Many of his ADHD clients showed specific nutritional deficits, such as zinc deficiencies, and improved when he encouraged them to take mineral supplementation, taking zinc tablets. Some of these individuals improved so much that no psychological services were needed. Others did very well on a combination of nutritional supplements and neurofeedback. He also found that many of his anxiety patients often calmed when given nutritional supplements. In addition, he used well-documented cognitive behavioral therapy and biofeedback protocols for anxiety. So he was following well-tested protocols. Some of his nutritional interventions were not entirely accepted worldwide or nutrition-wide, the field of nutrition and dietetics, but they were at least interventions which had some research documentation in scholarly journals. He was in an affluent suburb, and this integrative approach to treatment became very popular, and his practice thrived because he had patients who were very interested in this combination of nutritional, biofeedback, and psychotherapeutic intervention. Now, one of his local colleagues, a psychologist, filed a complaint with a state licensing board alleging that he was practicing outside the scope of practice for the Psychology Licensing Act. Well, in a simplistic sense, he was, because he was doing nutritional prescriptions, but he had a CNS certification for nutrition. So he and his attorney were actually not concerned. He retained an attorney. He filed a brief with a licensure board documenting that each of his interventions fell within the scope of practice of one of his 2 professional licenses or certificates. When I first learned about this case, I was one of many people who provided depositions supporting what he was doing. He had leaders in biofeedback, leaders in nutrition, and 2 physicians who were supportive of integrative healthcare who provided depositions supporting that these were technically well-supported, evidence-based interventions, and that they were following best practices in nutrition and psychological treatment. So my first reaction would be, this looks like an ethically appropriate intervention that he's engaging in, and a legally defensible one. He has obtained the appropriate training and the appropriate licensure and certification. So should he have done something differently? I personally didn't believe he should have, but he was censured by his state licensing board. He had to pay a fine, and he was allowed to practice only under an action plan, and that action plan was very strict. According to the board, his marketing strategy amounted to a, quote, bait and switch practice. In other words, somebody came to him for psychological services, and he pulled away the psychology and gave them nutrition instead. So they got something else and paid for something else other than what they originally contracted for. He was instructed that any new referral must be scheduled either as a client for nutrition or as a client for psychological practice. No session should ever include both types of service. His guideline, his action plan stated, if he was with a psychology patient and he perceived a potential relevance for nutritional counseling, he must refer that person to 3 licensed nutritional counselors, and one of them could be him. And if they accepted him as the referral, they would have to return on a different date scheduled for a separate nutrition session. The same thing had to happen if he was with a nutrition patient, somebody who originally requested his services as a certified nutritional specialist, and he perceived a value of them receiving psychotherapy or biofeedback or neurofeedback, he must refer the patient in the same fashion to 3 professionals, and they would have to choose whether to see him or somebody else. So right away we're getting a fragmenting of the integrative care. He was so disgusted that he actually moved geographically to a state where he found a licensing board that would allow him to practice the nutritional and the psychological interventions in one integrative practice in one session. So here's another example of a typical ethics case. This individual was very excited about heart rate variability biofeedback. He had the credentials. He was a licensed psychologist and BCIA certified in biofeedback. He told his patient, Cindy, that HRV is now the state-of-the-art treatment nationwide for panic disorder. Well, that's clearly an overstatement, because most professional psychologists and psychiatrists and primary care doctors don't even know what HRV is. It's not the state-of-the-art treatment. This particular patient had trouble with the biofeedback technology and computer interface, which were difficult for her. I've had that problem occasionally. Usually we can introduce simple handheld biofeedback devices and people can get past this technological phobia. But in her case, she never got comfortable with the biofeedback or the computer. After 6 weeks, she dropped out of treatment, and 6 weeks later, the psychologist received a notice from her attorney that she had been successfully treated with cognitive behavioral therapy and an SSRI. She later sued him for misinforming her about the current research and providing an experimental therapy when empirically supported therapies were available. So what could he have done to avoid this lawsuit? Well, I've provided heart rate variability and respiratory biofeedback breath training to many patients with anxiety disorders. I always inform them that it's still a minority treatment. It's well supported with research. It has a good rating in the new evidence-based treatment book, which I mentioned earlier. But most experts in anxiety disorders are still recommending cognitive behavioral therapy and medication as the best supported recommendations. Nevertheless, I tell them that I've been having a lot of success recently with patients with very similar symptoms, and if they're willing, I will give them some cognitive behavioral therapy as well as some heart rate variability training and breath training. And I've never had a patient turn me down, and I've also never had a complaint, but I also don't persist when somebody continues to be uncomfortable. I don't insist on using biofeedback. Okay, here's another ethical challenge, inappropriate touch. Well, that sounds terrible, but what this person did was relatively minor. This is a licensed psychologist and a certified biofeedback practitioner. He emphasized teaching diaphragmatic breathing for anxiety management. He instructed a female patient, Alice, to place her hand over her abdomen to feel the process of respiration. We often teach people to feel their chest and their abdomen and notice where the dominant activity, muscular activity is. Ideally, they should learn a diaphragmatic paced breathing, which involves larger excursions of the diaphragm in the abdomen and smaller activity in the chest. But she had trouble learning the diaphragmatic breathing, so he asked her permission to place his hand over hers on the abdomen. He was touching her hand, not the abdomen. He used moderate pressure to increase her awareness of the expansion and contraction of the abdomen during breathing. She later filed a complaint with her HMO stating that he had touched her inappropriately. Now, did he do something unethical or professionally inappropriate? Was there some step he could have taken to avoid this situation? Well, I've discussed this particular case with licensing board members, long-term professionals in biofeedback and psychotherapy. And the consensus is that he didn't do anything unethical or completely inappropriate, but he might have done something stupid. And that is, there are a lot of good interventions he could have undertaken, which would not involve his placing his hand over her hand on the abdomen, which is what she later complained about. He could have asked her to lie down on her back, in his office, and placed a large book, such as the Schwartz and Andrasik biofeedback practice book. It's just the right size for this kind of an exercise, or a 2-pound bag of rice a patient can use at home, and place that weight on their abdomen and let them feel the rise and fall of the book or the bag of rice on their abdomen, placing the same kind of pressure that he did with his hand. This is something that I've had many patients do. We also can shift and do biofeedback directly. I can use a respirometer, a respiratory sensor over the abdomen so the patient can see their abdomen rising and falling, displayed on the computer screen. And I've never had a patient who couldn't learn paced diaphragmatic breathing watching their own breathing on the screen. So there are lots of good options. The other comment I've had, and I think it was actually true because I knew this provider, several practitioners said this practitioner may have had a problem with empathy, may not have recognized that this patient was vulnerable, might have had an abuse history. A very high proportion of the female population has been sexually violated. And he might not have picked up on cues that this was inappropriate. Well, in fact, I did know this provider, and he was an individual who was trained as an experimental psychologist, not as a clinician, and he was somewhat stiff, very technically appropriate and very dedicated, not an unethical person at all, but probably not very strong in empathy. So we really have to build that empathic bond and the attunement to our patients. We also have to pay attention to their history and recognize that there are enough violated females that for a male to place his hand over the woman's hand on the abdomen, probably just not a good practice, even though it was intended to be helpful in an educational way. Now I'll give you one more example like that one, and then we'll stop for discussion. Here's another male working with a female, also teaching diaphragmatic breathing. He had appropriate skills. He instructed her to place her hand over her abdomen to feel the process of respiration. She took her complaint all the way to the state licensing board, stating that he had caused her to touch herself in a sexually inappropriate way. So is this an ethical violation? And in this case, again, I've discussed it many times with many audiences. No, I don't think this was an ethical violation. I think it shows that this woman probably needed to work with a female provider with a strong psychotherapeutic element because of confusion and troubled feelings about her own body. But he did not touch her. He did not ask her to touch her genitals or some private area. He asked her to touch her abdomen, which is a normal instruction in breath training, and something we would not want to stop doing just because one patient or client has an unusual reaction. So let's stop. There will be time for more examples next week. I will begin with neurofeedback next week, but I will talk about more clinical examples. I will also talk about the important ethical emerging area that we have to pay attention to: infection risk. The maintenance of sterile or disinfected sensors, and the risk that we can expose our patients to infections passed from one patient to the next. That's a very important emerging area. We don't have all the answers yet, but I want to at least raise each of your awareness of this area. So now, Jose, I'm going to invite that you, I'm going to put up my initial slide again as the screen, but I'm going to invite that you start reading any questions that are in the question box.
All right, thank you very much. And just as a reminder to everyone, you can send your questions via the question tab on your GoToWebinar control panel or the chat feature as well. Either one will work. You're more than welcome to reference to a specific page as well. That may help with some of the information. But the first question that we received is for the first early part of the session today. But it asks, what if the PhD is in education psychology? Would that qualify?
Well, first of all, it depends on what the practitioner is advertising themselves to do in practice. BCIA does certify educational psychologists, and educational psychologists frequently provide very expert practice in neurofeedback. But if the person has training only in educational psychology with no clinical background and is now conducting a clinical practice, let's say doing psychotherapy and neurofeedback with sexual abuse victims, then I would say it's at least questionable to use that PhD. If it were to be included on the card or in advertisements, I would want to put educational psychology in parentheses after the PhD, because otherwise you're going to be misleading many of your potential patients that you have a PhD in clinical psychology, which is not the case. The person might have a very appropriate, let's say a counseling license or a social work certification, which allows them to do the work they're doing, but the PhD is not necessarily relevant for this clinical population. So what we're avoiding is to mislead the persons who are requesting treatment. Now, I'm going to decline. The next question actually asks me the state that Sander was practicing in, the individual who was holding the practice in nutrition and psychology. I'm not going to answer where he was practicing, because I think that would be the kind of detail that might disclose his identity. He has given me permission to use his information in ethics training, but I think giving his location is in this sense, it's just like disclosing too much about our patients in a case narrative we later publish. I've been in a professional meeting, a national professional meeting, where somebody stood up and said, I know who the person is you're talking about. She's my cousin, and I want to ask you a question about her. So we can give too much information, and then we actually are disclosing identity.
Perfect. Thank you very much. We have one more. Let me see. BCIA versus certification biofeedback in a business card. Can you explain more?
Okay. Well, first of all, including your BCIA certification is, we strongly recommend that. I'm on the BCIA board and I'm their ethics chair. And we strongly recommend that you advertise your BCIA certification, because it does convey relevant information to your potential clients or patients, that you have the assurance of entry-level competence. So it's not inappropriate at all. It's not like if you've got a chemistry PhD, putting that on your clinical business card, which is misleading to the patient.
Thank you very much. We have another one here. Which states seem to be more restrictive in providing integrative care, and which seems the least restrictive?
Well, I know that California, where I teach at Saybrook University in Oakland, California, and I know that California is an example of a state that is extremely open to integrative care and the use of complementary therapies that are outside the mainstream. But I would have to say the map is changing every day. Medical schools, when they do their JCAH training, and hospitals, when they do their reaccreditation with JCAH, are being asked to document training in integrative medicine. Hospitals are being asked to document services in integrative medicine. So there is an increasingly broad acceptance nationally in integrative medicine, but nevertheless, licensing boards are conservative. They're basing decisions on their own training, what has become widely accepted, and whenever you do something new, it's possible that you'll be doing something the licensing board in your own state hasn't yet come to terms with. So I recommend you read the licensing law for your home discipline. And if you have a question, find a representative of the board that you can communicate with. Ask for a telephone conversation or an in-person meeting. And if you want to challenge something, do so, and get an expert in the field to help you challenge. My student, our graduate, went to the licensing board herself in North Carolina, and they were very hospitable to her and encouraged her practice. Now, if somebody should file a complaint, she's got a written opinion from her licensing board. So I can't say this state is better than another, because you might be in Iowa and there might be one area in which the Iowa board is very progressive and another area in which they're conservative.
Perfect.
So
Wonderful. Thank you.
Learn to know your board.
We have another question. Is asking a happy patient to write a Google or Yelp review a dual relationship that would interfere with therapy?
I think that's actually an important question that no one has ever asked me before. I think it would be most important, if you're going to do something like this, that you do it at the close of therapy. Now, that's not to say that it couldn't have backlash later on if the person returned to treatment and they had written a critical review and it bothered you and you weren't as entirely empathic as you tried to be. But I think if you're going to give that type of information to your patients, I'm present on this website, and if you'd like to post a review, I would welcome that. I think that would be fine, but I think it would make more sense at the end of treatment. Now, I've had patients who do it in the middle of treatment. That's fine. Of course, providers, I've had several colleagues who were quite upset because it seems like people who are dissatisfied are more likely to post. And we might believe that 90% of our patients are happy. Those may not be the ones who post.
Perfect. Thank you very much, Dr. Moss. It appears that those are the only questions we have received. I do have a couple more announcements since we do have a minute, and we'll see if any additional questions come in. But I just want to thank you for a wonderful presentation, and a reminder to all the attendees that you will be receiving an email with an evaluation and exam shortly. So please complete these to receive your 1.5 continuing education credits. Also, at the end of that exam and evaluation, there will be a confirmation page. This can serve as your CE certificate, so please remember to print that last page out. Once you exit the system, you won't be able to get back in there. Let's see, we did get a couple more questions. Hold on one second. One is, are there some boilerplate informed consent forms available?
That's a good question. I'm going to ask BCIA whether we can provide any. I don't have one that I think would be suitable across practices, but I'm going to ask BCIA if we can generate them. I think that's a very appropriate request. It might take longer than this week and next week, so if that's something you want, please email AAPB and also me. My email is up on the screen right now, and I'll make it a priority to get some boilerplate informed consent forms. I've been trying to find the ones I used to use with, for example, audiovisual entrainment, and I just haven't been able, I don't use them anymore because I regard this area as one that's now much more widely documented, so I'm not using informed consent. I might if I was brand new in practice. Never hurts to get extra consents. It also never hurts to consult the physician because it's also good for your professional relationships with the medical community. And every time I've talked to a physician, I've typically gotten at least one additional referral within a week or two. So I recommend caution in this area.
All right, we have 2 more questions if you're okay with that, Dr.
Good.
Moss. One is it ethical to state that I am experienced in several mind-body techniques, for example, meditation, breathing techniques, to my clients rather than trained? Would that be considered a slippery slope?
I think you can make that statement because we do cultivate a number of skills, and if we regularly utilize those interventions in our practice, I think it should be up. And let's say if you've got a bio on a website or some brochure that you want to hand out, John Smith or Louise Smith provides mind-body strategies useful for coping with many mental health and medical disorders. I think that's an appropriate statement. It's not the same as implying that you're certified in something you're not. And we don't have to be certified in every skill we use. I still use EMDR, even though I haven't taken an EMDR workshop in over 20 years. But I have had some additional supervision over the years from colleagues who are using it. And that's the kind of thing, well, I'm not going to stop using it, but I don't use it enough that I'm seeking out the certification. And our scope of practice allows us to do that.
Perfect. That is awesome. Thank you very much. Just so to let you know, we've had some great comments on the question feature. Just saying thank you very much for all your knowledge, and I thank you as well. To the attendees, if you think of any additional questions that you would like to ask the presenter, feel free to email us at info@aapb.org, or as Dr. Moss says, his email is available on the screen as well. So again, big thank you to everyone for your participation, and I hope that everyone enjoys the rest of their day. We hope to see you next Friday for the second part of this, and don't forget to check out our website for our annual conference, which will be held in April in Orlando, Florida. Registration is now open. Thank you, Dr. Moss.
Thank you very much, Jose, and best wishes.
Thank you. Take care.